This is the lecture for cardiopulmonary procedures for Clinical 2. As you can see here on the screen, this particular PowerPoint has 191 slides. We will try to get through several of these. I'm not going to read each and every one of them to you, so there might be some that we skip. And obviously we're going to break this down into several different parts. I'm not going to try to do it all in one or two lectures. So let's get started. With the introduction to electrocardiography, which is ECG, we talk about what is an ECG. Typically we hear it called an EKG, but remember from terminology, the gram, graph, graphy. The gram is the record, the graph is the instrument, and then graphy is the actual procedure. So we know that with EKGs or ECGs, we can get a good bit of information on how that heart is actually beating and acting within the chest. So we do that typically. It's a very nice non-invasive procedure that we can do in just about 10 minutes, and the patient typically does not have any distress from that. There might be a little bit from those electrodes sticking to their skin or maybe pulling some hair, but that's not too bad. So why do we do electrocardiography? We're going to evaluate several things: chest pain, shortness of breath, dizziness, and heart palpitations. Sometimes you may even have a patient that comes in needing an EKG for a fitness for duty, or maybe it's part of their annual testing that they have for insurance. But these are the primary reasons why we would want to do an ECG with a patient that was symptomatic in the office. So hopefully we're going to find what's causing this problem. So one of the first things that we can see is a dysrhythmia. Remember from terminology, dys is abnormal, difficult. So we might see a rhythm or heart rate that is abnormal. We also can detect if there is any ischemia. And remember, ischemia is the absence or the impaired sluggish blood flow to an area. So this is something that's going to cause problems if it continues, or it might be there because the patient has already had a heart attack, or what we typically call an MI, which is that myocardial infarction. And then we also want to use that ECG to determine if there's any hypertrophy of the heart noted. There's also some other things: myocarditis and pericarditis. And if you remember back from terminology and even in theory, there were those three layers of the heart: the pericardium, the myocardium, and the endocardium. Well, the myocardium is that middle layer that we typically see is damaged from a myocardial infarction. And then the pericardium is that outer layer, which is the big protective sac that encloses the heart. You can also see here that we can use an EKG to give us some information on how well a patient is responding to medications. We also can see if they have like a bad electrolyte imbalance. Sometimes that will affect the heart rhythm, and that's something that we want to be very careful about. Okay. Now, an EKG or an ECG cannot detect all the cardiovascular disorders, but it can give us a good bit of information. Believe it or not, it can't always even tell us when someone's having a heart attack that is just about to occur. Just for personal reasons, I know that someone has had a heart attack, and unfortunately that EKG did not pick it up, and it was very, very recent, like within the matter of hours. So we know that it is definitely true what the textbook is telling us about that. So looking at all those little bumpity bumps on those little cute little red squares on an EKG reading, the actual electrocardiogram, what it's doing is it's recording about 10 seconds of the heart's activity, and we're going to be able to see how it's working within the different areas of the heart, and we'll talk more about that very soon. We also do EKGs for patients that are having angina pectoris or angina. That is our medical term for chest pain. So you've probably heard that before, especially in terminology and in theory. So what all kinds of information do we need in order to complete the assessment of the cardiac functioning. You've got to have this bit of information in order to completely assess that patient. You've got to have their symptoms, their health history, the physical exam, and then any of the other diagnostic tests and procedures that you might be performing there. So what are our responsibilities as a medical assistant for running that ECG? Some of the things include preparing the patient, making sure that we can operate the actual machine, identifying and maybe eliminating some artifacts, and then care and maintenance of the ECG machine itself. Okay, so those are some pretty important things that we'll be responsible for doing as we are performing an ECG, or maybe even preparing to do that ECG. So, what are the formats? Well, this is a single channel format. It's one lead that's being recorded at a time, and then there's also the 3-channel format, which is the 3 leads. Most offices are going to use the 3 leads, and typically that's the same even in the hospitals. So let's look at the heart itself, just the structures of the heart. Remember, it has 4 chambers. The upper chambers are called atrium, and the bottom chambers are called ventricles. Remember that the lower chambers are actually a little bit larger than the bottom chambers. So let's kind of refresh our memory on the blood flow through the heart. Blood enters the right atrium from the superior and inferior vena cava. Then it's brought back to the heart after circulating the body. It enters the right ventricle, it pumps into the lungs where the pulmonary artery takes it to the lungs, and then we're going to pick up that oxygen. Then it returns to the left atrium of the heart through those pulmonary veins. Remember, those are the only 2 times that you're going to see veins carrying our bright red blood, meaning that it is rich in oxygen, and then the artery carrying oxygen poor blood, which is more of a Merlot color. Then the blood's going to enter through the left ventricle, and then it's going to be pumped into the aorta. Then it's going to be carried all throughout the rest of the body, because that big aorta pushes it out with those nice hard contractions. Now, that's also going to distribute not just bright red blood, but the reason why it's bright red is because it's full of oxygen and other nutrients. So what about those coronary arteries? Remember, corono, if you remember from terminology, that means crown or circular. So the coronary arteries are those 2 small arteries that branch off the aorta, and they go around the heart, and we want to make sure that those have always got good circulation. So let's look at the conduction system of the heart. The first thing we want to talk about is the natural pacemaker of the heart, which is the SA node, sinoatrial node. It's actually located in the upper portion of the right atrium, just below the opening of the superior vena cava. It has a little knot that's modified myocardial cells, and then it actually sends out all those big electrical impulses without any external nerve stimulus, so it does it on its own. So because of this, it's supposed to regulate the heart rate and the heartbeat, and that's why we call it the natural pacemaker of the heart. So the path of impulse from the SA node, so it's the actual electrical impulse is discharged from the SA node. The impulse is distributed to that right and left atria, which causes the atria to contract. So that's where we hear that. What part of the blood pressure are we talking about when the heart vessels contract? That's the systole. All right, so then the impulse is picked up by the atrioventricular node, or the AV node. Then that AV node delays the impulse momentarily, just for a moment, and then the impulse is transmitted to that bundle of His, and then the bundle branches. So then those bundle branches relay the impulses to the Purkinje fibers, which now we see that impulse evenly going out to the right and left ventricles. So that's just a good little picture of how that heart is contracting and how the blood's entering and leaving. So let's look at the cardiac cycle. What is a cardiac cycle? Well, it represents one complete heartbeat, okay? So that's one complete heartbeat. So we have the contraction of the atria, the contraction of the ventricle, and then the relaxation of the entire heart. So on that EKG, we're looking at that with every heartbeat. So that cycle is being shown and represented on that little paper with all the little bumpity bumps. So I keep saying bumpity bumps, and this is what I'm talking about. So the EKG cycle, it's composed of a P, a QRS, and a T wave. So the P, QRS, T, just like it is in the alphabet, you're going to see these parts represented in that one cardiac cycle of the heartbeat. So let's talk just a little bit about what is the P wave and what does it represent. So the P wave is that first little bump that you see in that cardiac cycle, and what it's going to represent is the contraction of the atria. And the P wave, when we're contracting the atria, this is known as atrial depolarization. Atrial depolarization. This is very important. Then we get to our Qrs complex. Okay, so that's your Q, your R, and your S part of the wave. And this is representing the electrical activity that's associated with the contraction of the ventricles. So now we've gone from the top part of the heart contracting in the P wave, that now we're at the bottom of the heart and those ventricles, the large parts, and they're contracting. So this is called ventricular depolarization. Okay, so the P wave was atrial depolarization. The QRS complex is known as ventricular depolarization. And with this, the ventricles, they're actually larger than the atria. We got to keep that in mind. So they require a stronger electrical stimulus to depolarize the ventricles, which causes that R wave to be taller than the P wave. Okay, now we get the T wave. So P, Q, R, S, and now T. And this is representing that electrical recovery phase of the ventricles that we call ventricular repolarization. So we had the two depolarizations. Now we're at the repolarization at the T wave. So what's going on here are those muscle cells they're recovering, and they're preparing for that next impulse that's going to happen. So you're going to see the atrial repolarization start all over again because you're going to have another P wave. So then this continues to happen every time that the heart pumps. So there's oftentimes another little wave that we will notice, and it's called the U wave. So it's typically going to follow that T wave, and it's usually really small, and it's going to be associated with repolarization. Repolarization, okay? So let's look at a little bit more information about the ECG and what we're talking about with how it looks on the paper. So you have a baseline, and it's the flat horizontal line, and it separates the different waves, okay? It's going to show us when the heart is at rest, meaning that it's polarized. It's resting up, so it's recharging, if you will. It's polarization. There's no electrical activity happening at this point, so there's nothing to record. There's just a flat line, okay? Now, when the waves deflect either upward or downward from the baseline, we say that it has a positive deflection, which means that the waves are going up, or there is a negative deflection where the waves are going downward. Okay, so then it's talking about here that the EKG is divided into segments and intervals between the P and the T wave. So why do we do that? Well, that's how we actually read the EKGs. So the segment, which is the portion of the EKG between the two waves, we have that P to the R segment, and this is the time interval from the end of atrial depolarization to the beginning of ventricular depolarization. So the time between atrial depolarization and the beginning of ventricular depolarization, okay? That's really, really important for that P to R segment. Then our ST segment. This is from the end of the ventricular depolarization to the beginning of the repolarization of the ventricles, okay? So let's look at this again. So we have the P, which is that first little bump right there. That's the P wave. Then you have your P to R segment, what we just talked about. Then you have your Q, which is a negative deflection. The R wave is an upward deflection, so it's actually going to be a positive upward deflection. Then we come back down to the S, and then we go back up to the T, and then every now and then we might have this little U. So that break in between each heartbeat or segment, that's called the baseline. Okay? Alright, so let's look at intervals. Intervals, this is the length of a wave, or the length of a wave with a segment. So here we're going to actually talk about P to R intervals. See on this picture here, we said the P wave, and then we had the PR segment, but we also can look at this amount of time from the first moment that we make this positive deflection all the way over till we make this last deflection, and this is the P to the R interval, okay? So what's happening here, this is the beginning of atrial depolarization to the beginning of ventricular depolarization, that first part of the heartbeat. That is when we're seeing the atrial and ventricular depolarization from P to R. Then we have the Q to the T, which is the time interval between the beginning of the ventricular depolarization to the end of repolarization of the ventricles. Okay, and then we go back to our baseline, which is after that T wave or the E wave, where the heart's just resting. And remember, that resting period is called polarization, or we call this polarized state. Okay, so here are the intervals again. That just gives you another idea as to how that looks. So let's talk a little bit about the paper, and that's really important. So the EKG paper, it's divided into two sets of squares. You have the real tiny squares, which are 1 millimeter high and 1 millimeter wide. Then you have your bigger squares that are 5 millimeters high and 5 millimeters wide. So each large square is made up of 25 small squares. You with me? Not a lot of math, just pretty easy. What the physician does is that he will use that and do some measuring to actually look at the waves, the intervals, and the segments, and he'll decide what are these normal limits and does this fit within the normal limits. Okay, so heart disease can tell us there's going to be some changes with their EKG. So we're going to see different things like cardiac ischemia. We might even see a myocardial infarction. So the paper is thermosensitive, and it's covered with this thermosensitive stuff. Typically it's red graph paper, but sometimes it can be black. And then the thermal print head produces the ECG tracing. So it generates the heat in a prescribed pattern to follow that rhythm that the heart is going through. So when it comes into contact with the heated print, the coating of the paper turns black where it's producing the tracing. And there's also this note where it says the paper is also pressure sensitive. So when you handle it, be very careful, because by pressing real firmly you can make some marks on that ECG. So the standardization of the EKG, this is really important. The standardization of the EKG, we have to do this for every recording because it is quality control. You know, quality control is a must. That's the way that we know that instrumentation is properly functioning. So, just like with any other piece of equipment, we're going to have that with our ECG. It's also going to mean that our ECG is going to run on one EKG type of paper, and the instrument is going to be compared in accuracy by running that with another machine. So the normal standardization mark, now this is very important, the standardization mark is 10 millimeters high, which means that, remember, it's 10 small squares, by 2 millimeters wide, which is 2 small squares. So up 10 and over 2. You're going to see that standardization mark at the beginning of every EKG. Very, 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 very important. All right, and remember we're using those 3-channel machines. They automatically record that standardization mark, but if it doesn't, we've got problems. Now, what happens if that is more or less than 10 millimeters? That machine has got to be QC'd, and you probably have to take it out of commission until it is reviewed by a some type of mechanic that can work on that. Your company may have a little policy where they can send that machine back and kind of like a warranty and get it calibrated, if you will. And we're going to stop there and then pick up on the leads with the next lecture.